Hi, everyone. Welcome. My name is Perry Kim. I'm the Assistant Scientific Director at the Canadian Frailty Network. I want to thank you all for attending today's webinar. To start, I'd like for us to acknowledge that the Canadian Frailty Network and Queen's University, our host academic institution, is situated on traditional Anishinaabe and Haudenosaunee territory. We are grateful to be able to live, learn, and play on these lands. Today's webinar is titled The Road Ahead for Quality and Long-Term Care, Collaborative Approaches to Evidence-Informed Decision-Making. Our speaker today is Dr. John Hurdes, professor at the University of Ottawa. Now, before we get into the meat of the matter, I'd just like to remind everyone that John will answer questions after his presentation. And for those interested in posting questions or asking questions, please click on the Q&A button and I'll read off as many questions as possible as time permits. Just as a reminder, slides and video of this webinar will be available on our website within 2 days or so. I also want to remind everyone that our next webinar is currently scheduled for March 10th at noon Eastern Time. The title of this talk is Results from the Targeting Better Outcomes for Frail Elderly Patients, Advanced Care Planning Cluster Randomized Trial. Dr. George Heckman will be the speaker. He's from the University of Waterloo, a colleague of John's. And lastly, I want to encourage people to monitor our website for new webinars as we develop them. So today's speaker, as I said, is Dr. John Hurdes. He is a professor in the School of Public Health Sciences, the University of Waterloo, and a fellow of the Basili School of International Affairs. In addition, he is the Senior Canadian Fellow and Board Member of INTERI, an international consortium of researchers from over 35 countries. He chairs INTERI's Network for Mental Health and the INTERI Network of Canada. Dr. Hurdes has over 250 publications in peer-reviewed journals and academic book chapters. Among his awards, he's received the University of Waterloo Award for Excellence in Graduate Supervision, Faculty of Health Graduate Mentorship Award, and Queen Elizabeth II Diamond Jubilee Medal through the Canadian Home Care Association and the Canadian Association on Gerontology. Now, those are impressive credentials. The thing that most impresses me about John is the fact that he is an author of a children's book titled Wilfred the Vegetarian Crow. Quite impressive, John. So with that, I'd like to hand it over to you to share your screen and begin your presentation. Oh, John, you're muted.
There we go. Thank you for that, Perry, and thanks for the shout out for my kids' book for sure. That's I guess it's an upgrade from when I was cited in Reader's Digest. That's when my late mother-in-law thought I'd really made it when I was in Reader's Digest. Perry, can you see my slide okay?
Yes, I can.
Okay, fantastic. Thank you so much. So thank you, everybody, for joining us today. I'd like to talk about research that we've done with a variety of different projects, including a major project funded by Canadian Frailty Network that we're very grateful for that support. And my aim is to try to take a bit of a big picture view of, given where we are today, and the public interest in improving quality and long-term care, what do we need to do to get there in terms of having a better long-term care system? And my argument will be that the only way we're going to be able to get there is if we're working together collaboratively. So I'd like to acknowledge for sure the great funding we've had from the Canadian Frailty Network in support of this work. Some of the research I'll be showing you is also funded by the Canadian Foundation for Healthcare Improvement, CIHR, the New Frontiers Research Fund, and the European Union New Horizons Fund, as well as the Senior Quality Leap Initiative. And of course, the work I'm presenting is not just my work. I've got a wonderful collaborative team of folks like Paul Hebert, George Heckman, Lou Turcotte, and many others that were part of this collaboration, as well as the Canadian Institute for Health Information has been a wonderful organization to collaborate with as well. So this is a reflection of efforts of many parties, not just my work by any means. So what I'd like to talk about a bit is first with some I guess, some basic comments about what's the relationship between data and evidence and how we make decisions in healthcare settings. I think it's sort of important to give some thought to what the limitations are of the data and evidence we have available. But I'd really like to focus most of the discussion about the quality of long-term care, both in the pre-COVID and the after COVID. I'm not sure we're after COVID yet, but hopefully we'll soon be there. The road going forward in terms of quality after the pandemic subsides. And I'd like to put the emphasis that a key aspect of all this is that we have to be able to work together effectively for this. So one of the phrases that I'd like to expunge from our usage permanently is the idea that data speak for themselves. Data don't speak for themselves. What this data set tells you is that and nothing more. We need to think about data and evidence in a context, not just sort of look at numbers and assume that their meaning is self-evident. So my PhD supervisor, Bill Forbes, when I was a graduate student, had a sign on his door quoting Theodore Roszak that said, data, data everywhere, but not a thought to think. So Theodore Roszak, he was the guy behind the idea of counterculture, but his argument was that you can't just use data on their own. So big data aren't enough for us to be able to transform the healthcare system. But he said what we need are big ideas, and big ideas where good quality data are analyzed with sound scientific methods, and that's where we can start to drive change. And so we need to think about the methods we're using, what the meaning of data is, and think in a collaborative fashion about how we would apply those to questions that are of critical importance to us. So if we think about transforming the long-term care system using data to inform our decisions, there's a whole bunch of different kinds of questions or decision points that we need data for and evidence for. So we need to be able to identify and respond to the needs, both at the individual level, where we can put a personalized care plan in place to respond to the person's needs, but also at the population level, so we staff resources appropriately and we provide the right set of services based on population needs. We need to make decisions about how we allocate resources. We need to monitor the outcomes that we're interested in. We need to evaluate quality and evaluate performance of any health system overall. And we need to use all that evidence to then make modifications and refinements to the health system. And all of that was true both before a global pandemic hits, during a global pandemic, and certainly afterward. We need to be able to use data for all these decision points. The questions that come up and the challenges we face may vary depending on whether we have another global pandemic or not, but these are the kinds of things we should be thinking about using good quality data transformed into evidence to inform our decisions. So if I think about long-term care in Canada before COVID hit us, and we had several strengths in the long-term care system in terms of information resources that were there. So a major strength that we had is that there are multiple inter-eye instruments implemented across the country in most provinces and territories. I think we're now at a point that almost every province or territory is implementing or has implemented one or more of these instruments. But an important consideration there is many of the provinces are still using the oldest version of the inter-eye instrument in the nursing home sector. And that actually became a problem during the pandemic. And I would also say that our use of the data for decision-making in clinical practice is not at the level it should be today. We certainly have underused those data for those purposes. We actually have a pretty robust IT infrastructure for long-term care and for national reporting of long-term care data. In many ways, I would argue that the data systems we have for long-term care are better than they are in the acute care sector. And we have great public reporting mechanisms now to report on quality in long-term care that CIHI has established well before the pandemic. But the pandemic revealed some important weaknesses for us as well. Whether we had a pandemic or not, we are under resourced in terms of measures of quality of life or resident experience. British Columbia and New Brunswick have begun to adopt a common standard and have some evidence around resident experience and quality of life. But for most of the rest of the country, to my knowledge, we're not really there yet in terms of a pan-Canadian comparative standard for the subjective aspects of quality of life. The pandemic revealed some serious weaknesses in terms of public health reporting mechanisms. So it was a bit of a shock to me as somebody who purports to be an expert in long-term care to be called by reporters in June of 2020 about outbreaks in long-term care, where the reporter had better evidence about outbreaks than I was able to access as a scientist who's been working in the field for almost 30 years. The system's gotten a bit better than it was at the start of the pandemic, but it's still underwhelming. And I'm struck by the ability of governments to decide to report or not report public health information as they wish with respect to long-term care. We also have seen some real gaps in terms of structural measures. The Statistics Canada Residential Care Facilities Survey will help to remedy some of this, but something as basic as staffing is actually remarkably difficult to get data on across the country in a consistent, standardized manner today. And that's important for us because that's a really critical variable to understand in terms of the adequacy of the resources, the relationship between staffing and quality, and how that may have been affected by things like the pandemic. There's also many process measures we don't have great mechanisms in place yet. So if we look at vaccination in New Brunswick, who are using the newer version of the INTRI instrument, we can track influenza vaccination in long-term care home residents, no problem. In fact, we just had a paper accepted by BMJ Open on work funded by CFN that shows the experience in New Brunswick compared to experience in Netherlands and New Zealand. But in Ontario, where we're using the older version of the INTRI instrument, we do not track the influenza vaccination in long-term care, and it's much more difficult trying to track vaccination data with respect to COVID. We also came across some real challenges in terms of cross-sector ability to transfer clinical information, that there remain too many administrative and privacy barriers for people to share information from one setting to another. So for example, in work that we've been doing with Toronto Grace Hospital in Toronto, we found that it was actually quite difficult for the hospital to get information on geriatric psychiatry patients that had been discharged from inpatient psychiatry settings where they were assessed with awry mental health to provide continuity of care in their long-term care homes once those residents were discharged to that setting. That shouldn't be that difficult to do. That should be pretty much seamless overall. And then the other issue that the pandemic revealed, I think in very plain terms, is the inadequacy of clinical resources in long-term care. We've quite rightly put a lot of emphasis on improving quality of life and the home-like environment in long-term care, but we have not adequately resourced the sector for the complex medical challenges faced by residents in those settings. So then along came COVID, and like all of you, in March 2020, I thought, okay, this is something that could be potentially big. It could last weeks if our experience with SARS was anything. What was striking was how global COVID became very quickly, and how global the impact on long-term care was very quickly. It was really virtually every continent in the globe was being touched by the pandemic. So if we look back to March 2020 and we think about, well, what do we know at the start of the pandemic? And the answer was we really didn't know very much. There was almost no evidence available on what the impact of COVID would be in long-term care. There were reports from hospitals, mainly in China at the time, that we could draw on, but it was acute care settings. And then there was a couple case reports emerging from US long-term care homes, but not much else beyond that. What did come out was the argument that age and multimorbidity were something that we had to worry about. But it was very clear that at the start of the pandemic, we were putting our emphasis from a policy point of view on hospitals rather than long-term care or the home care settings. And that was a dangerous decision in my view. So in March 2020, we did analyses with INTRI data from Canada, the United States, and New Zealand in both home care and nursing home settings, using the evidence that WHO had put forward at the time that age and major and multimorbidities were key factors. And what we could see in all those settings, if we look at the highest risk age group, 80 plus, and look at major comorbidities being present, the overwhelming majority of nursing home residents were in those very high risk categories, and we had to be worried about those populations both in nursing homes and home care settings. We tried to use our data to do a proxy simulation model of what we might expect if COVID was bad. And what we did with that is we used data about pneumonia from 2002 to 2018 in home care and nursing home settings. So we took the WHO framework of age and comorbidity, and we added an overlay of pneumonia and looked at the mortality experience that we saw in reality pre-COVID, using the pneumonia as a proxy for how bad COVID might be. And what you could see is that higher ages, exposure to pneumonia, multimorbidity were all bad factors, posing substantial risk, particularly to folks in the nursing home setting. So in March 2020, using that proxy, we projected a worst case scenario of 1,115 deaths in Canadian nursing homes. For context, that at that time, we knew that 44 people died in the 2003 SARS pandemic. So we actually thought if we put this out there, people are going to think that we're alarmists by estimating that much bigger of an impact of COVID than what we saw with SARS. But we released the information to decision makers in March 2020 nonetheless. And we all know what happened after that. If we look at long-term care homes and retirement homes and assisted living, 14,000 people died after the first two waves, or about 10,000 residents in nursing homes. So what we thought was an alarmist estimate was a dramatic underestimate of what actually happened in the pandemic. What was also been interesting, though, is to take a look at the patterns of mortality that happened during the pandemic in the different waves. And what's interesting is that not all homes had deaths, not all homes had massive outbreaks. In fact, there were some homes that came through the pandemic reasonably well and others that had much worse experiences. And so it's worth thinking about, well, why were deaths concentrated so much in a subset of homes? Why was the death rate worse in wave two? And why did some homes have bad outcomes compared with others? So I had the opportunity to collaborate with our colleagues in CIHI, led by analyses done by Luke Turcott, who was also on our CFN grant, as well as other collaborators in CIHI. And we analyzed the data in collaboration with the Long-Term Care COVID Commission in Ontario to find out what was related to having an outbreak in long-term care homes, what was related to having a bad outbreak and high resident mortality, and what was related to very high resident mortality overall. There were several factors that came out that had already been in the public discourse around staffing and chain ownership size of the facilities and geographic outbreak. But a couple of things that were interesting that came out from that work is, first of all, the performance of the homes based on inter-eye quality indicators reported by CIHI prior to the pandemic turned out to be predictive of higher likelihood of outbreaks in the home. And that staffing variable that I mentioned that we have a hard time getting, we were able to get through a survey of the Ontario long-term care homes. We provided clear evidence that higher staffing levels were related to lower likelihood of an outbreak. But another kind of structure or process measure, depending on where you want to fall off the log and classification for this that we found from this work, was that if the medical director was present less than a day a week on site, that was related to worse outcomes and resident mortality. That's new information that we were only able to get because we did a survey of the long-term care homes, and those survey data are no longer available. So structurally, we do not have that information available readily for all long-term care homes in the country. But it's also important to think about other outcomes that we would be interested in related to the pandemic, including the consequences of the lockdown. So there's three projects that we're involved in that are relevant to this part of the discussion. There's a network called the Senior Quality LEAP Initiative, or SQLI, which is a Canadian, US, and actually South African collaborative network of long-term care homes in those three countries, as well as partners like CIHI and the Health Standards Organization, where we're working in a collaborative network to improve quality. I'll show you some results from a pre-COVID study we did with CFHI around antipsychotic use and how that relates to current antipsychotic use. And then our CFN funded project was with a francophone network of long-term care homes called Les Visionnaires that was based in New Brunswick, Manitoba, and Ontario, where we took the work being done in the Anglophone SQLI network and applied it to the Francophone network to see if we could replicate some of the positive findings that we had there. The exciting thing is that it looks like there's now likelihood of this effort of Les Visionnaires to scale up to a provincial level. Nothing has been formally announced yet, but there's certainly positive signals that that may be the next step of sustainability for that CFN funded work. So let's think for a minute about why working together is actually a good thing. It should be obvious, but let's remind ourselves of some of the key points there. Well, first of all, by working with other long-term care organizations, it gives you a context to understand your own performance. So you can tell if you're doing well or not so well by comparing yourselves with others rather than only looking at yourself in the mirror over time. And when others do particularly well in performance and particular quality indicator, you can see what can be achieved, what's possible to do in terms of quality. Also, innovation takes effort, and by working with others, you can pool resources to support innovation through that shared effort. By working together, but doing things a little bit differently, you can do natural policy or clinical experiments with that work. You can avoid reinventing wheels or avoid bad things that would happen if you go down a path that's not particularly fruitful by learning from the experience of others. You can also speed up your adoption of effective practices. If somebody else figured out that something works, you don't need to retest it. You might be able to implement it much more rapidly without having to go through all the early developmental phases. And also, it's good to have a support network that helps you when your dearly held beliefs or ideas about what's right completely fail, because sometimes we get it wrong in long-term care, and having colleagues that are supportive and understanding and help you to sort of get through the next stage is always a good thing as well. So here's a paper we studied from the Senior Quality Leap Initiative, which is now well into its first decade of work of this collaborative network, where they work together with an initiative to improve quality with respect to pain management. In the middle part of this, you can see the performance of the SQLI network in terms of moderate to severe pain, and you can see the rates drop down over time. These thick bars, the 20th median and 80th percentile, are the reference standards from the entire United States database for nursing homes that we can use to compare. So when the network started, the network was doing a worse job than the median for the US homes, and it improved to the point of being in the median. Some homes were doing better than the median, like sites 10 and 5, and they improved. Other homes were doing worse than the 80th percentile and improved their position to the median. And so this is through years of collaborative effort to try to drive down something as fairly challenging to do as pain, and we could sort of show that, yes, a network can collaborate effectively in that regard. So then I want to take a look at what's happened on a secular basis in the Canadian context, going back to 2012 all the way to the first year of the pandemic, using CIHI data reported in their Quick Stats portal. There's been lots of discussion about depression symptoms in long-term care. So this shows the distribution of the INTRI depression rating scale by year and in different provinces in long-term care. The green are the folks who have no depressive symptoms. The yellow part is where they have some mild potential symptoms of depression, and 3 or more is where you think there could be a potential depressive disorder in place. And so what's interesting with these data is if you see for Alberta, Manitoba, and Ontario, the long-term trend in long-term care has been improvement in depression scores, improvement in performance with respect to depressive symptoms. Newfoundland has gone in the other direction, that it seems that depressive symptoms have gotten worse in Newfoundland. In British Columbia, it's been a bit on the flat side overall. Complex continuum care in Ontario slightly improved, and Yukon bounced around a bit. So up to and including the first year of the pandemic, we've seen actually an improvement or sustainment of improved depressive symptoms in several provinces. The next thing that we did was, again with CFN funding, was to take a look at the lay visionaires' homes and during the first wave of the pandemic to try to understand the impact of the lockdown during that period. Now, New Brunswick was interesting at the time because they did not have COVID outbreaks, but they had the lockdown. So it's a fairly clean way to understand the impact of the lockdown without also being affected by the widespread occurrence of the COVID infection at the same time. And when we did the analyses of those New Brunswick data, we were surprised that we found that there was no effect during that lockdown period, or in fact, a mild protective effect for behavioral issues, depressive symptoms, or delirium after we controlled for a host of clinical and demographic and historical considerations. So that was a surprise. And when we spoke to the homes in the Lay Visionaires network, what they told us was, well, they increased recreation resources within the homes. They hired students to come and work in the homes. They deployed tablets to keep residents connected with their family members, and they had an effective communication strategy to keep family members engaged during that first wave of the pandemic. Next, I want to show you some quality of life evidence from the Senior Quality Leap Initiative. Now, this graph's a little bit complicated, so I'll break down the different pieces for you. The blue bars with the diagonal stripes and the solid part are the percentage of residents in the home that say that the statement is true for them most of the time or always. So a higher score is more people saying it's true. The gray horizontal bar with the dashed line in the middle is the reference standard from over 300 homes in 9 different countries prior to the pandemic. The bottom of the bar is the bottom 20th percentile performance rate. The top of the bar is the 80th percentile, and the dash line is median. That green arrow that you see is the performance of British Columbia long-term care homes prior to the pandemic in their homes. So for the statement of, I can go where I want on the spur of the moment, what you see is the SQLI homes that repeated the quality of life study during 2021 and the second, third, and fourth waves of the pandemic. Most of the residents in those homes were reporting rates of agreement with that well below the 20th percentile for the international performance and well below the BC performance. So no surprise, during the pandemic, residents reported that they weren't able to move around as much as they like at the spur of a moment. But then if we look at a summary scale of residents' appraisal of staff performance, where we have several indicators of how caring staff members are of residents in the home, we can benchmark that performance in the SQLI homes from 2015 all the way up to 2020 and 2021. And what you can see for this scale, for all years, the Canadian homes and the US homes in SQLI were at or better than the international benchmark performance. And in many of the homes, that performance continued to stay very positive during the pandemic. Even though staff were facing tremendous stresses and difficulties, they still had comparable ratings around this in the homes that participated in the study. Then we can also ask, the simple question that's very popular in resident experience surveys of, would you recommend this place to others? So in the pandemic year, you can see for most of the homes, they continue to be in the positive range, very consistent with pre-pandemic ratings of whether they would recommend the home that they were in compared with others. Some did worse in that, but for the majority of these homes, it was very comparable to pre-pandemic performance and consistent with the British Columbia performance prior to the pandemic as well. Next, I want to think about restraint use, because I think restraint use has been one of the great success stories in Canada over time. When I started doing research in this sector in the mid-1990s, I reported on one of the first studies on restraint use in complex continuum care hospitals in Ontario, and the rate was well over 40%. By the time we got CIHI reports after adoption of the MDS, it was a little bit better, but still north of 35%. Well, by 2019, that rate for complex continuum care was below 5%. The national rate for restraint use was below 5%. And you can see this pattern of change where most homes start off with a higher rate and then drop down in different provinces as they've adopted the inter-I system. So that posed an interesting question for the lay visionaries group, who had not really seen any of this English language literature, had not been using the intra LTCF until a couple of years prior to the pandemic, and so didn't really have a sense of the context for restraint use in those homes. When we reported the rates of restraint use to the visionaries' homes as part of the CFN funded project, here's what you can see. The thick vertical bars are the Canadian 20th percentile, the Canadian median, and the Canadian 80th percentile. So you can see these homes in New Brunswick had substantially higher rates of physical restraint use in those homes compared with the rest of the country. So by 2017, we'd already provided this information to those homes, and they decided, okay, we're going to work together to see if we can improve these on this performance. Some of these homes had dramatic changes. So home D went from a rate about 70% to a rate below 10%. Home E, F, were other homes that had substantial improvements in it overall. There was another home that was already well below the best performance benchmark for the Canadian context. And a couple homes actually did worse over time. And so we could try to understand what happened in those homes that meant that their restraint use patterns deteriorated so that they could take corrective action. So this was the first time these homes had seen this evidence, and they took it very seriously and decided to take action in relation to that, because they knew that once New Brunswick went live with CIHI, those data would be publicly reported. So here's where New Brunswick is today. Now, I've highlighted York Care Center because York Care Center has been part of the SQLI network for at least a decade, so they're already well familiar with these indicators, and they've let me report publicly on their particular performance in the past. But if you go to the CIHI website, you can pull up the same screen today as I did, and you can see, well, the performance in New Brunswick for restraint use in the province was 26%. The York Care Center, which had been part of the SQLI network for some time, was around 12%, and the Canadian standard was at 6%. So what I see in the homes that were part of that collaborative network in New Brunswick, that they were able to take actions to start to remedy their higher rates of physical restraint use to become consistent with what was happening in the rest of the country. And those homes are well underway. Now what we need to do is scale up that work in the provincial level to bring New Brunswick into line with performance in the rest of the country. The next one that I'll show you is from the Canadian Foundation for Healthcare Improvement, Appropriate Use of Antipsychotics initiative, where we looked at the 47 homes that were part of the intervention homes in the CFHI intervention, which involved mentoring and data sharing and collaboration, much like the SQLI and the Lay Visionaries Network. And then we had homes in the rest of the country that were not part of that overall network. And what you can see is, looking at that set of control homes, is that there's a secular trend in the country for improvements in performance with respect to inappropriate antipsychotic use. So all those homes that were not part of the CFHI intervention were also improving. But we also see that that intervention had a steeper slope in the intervention homes that participate in the CFHI network. And a way to express that differently is that the homes with the best performance in CFHI had a 12% reduction in antipsychotic use compared to 6% in the control homes. The median homes, in terms of mid-level performance, had 10% compared to 7%. And the worst performing homes in the CFHI intervention improved by 16% compared to the 6% improvement in the homes above the 80th percentile in the control homes. So that collaborative intervention that CFHI launched helped those homes accelerate their improvement with respect to inappropriate antipsychotic use over and above the secular trends that were already underway in the province. So here's the bad news for all of us in every province and territory pretty much, is that now, with the pandemic having been in place for 2 years, in pretty much every province and territory, those gains that we had in reduction in antipsychotic use are at risk of being reversed. That antipsychotic use has actually gone up in long-term care homes in several provinces. In some cases, I can tell you from reports from members of these collaborative networks, they were instructed by public health professionals to do this in order to constrain resident movement, which was not a great idea. I mean, this was a good 5 years worth of work to improve quality that could be a major setback for us. So we need to redouble our efforts to correct that. So what are some of the common features of these collaborative networks? First is that they use the data that they had available to them. They supplemented the data where needed, but they made very good use of the existing data at their hands. They were also very open about sharing their findings with each other, whether those findings are good, bad, or ugly for their home. We had a protective cone of silence around the collaborating homes. So we share the information within the network, but we don't publicly identify homes in terms of their network results in public reports. As I said, the York Care home results that I showed here are on the CIHI public website, not from the SQLI reports specifically. We benchmark our data against national and international standards. We don't just look at ourselves, we use external benchmarks to evaluate quality. Our focus is on improving quality with a problem-solving orientation to that. That's what gets you into the network overall. Homes that had effective strategies and interventions shared those, and if we didn't have those, we brainstormed together to come up with testable solutions that we could try out. We also allowed flexibility. We did not impose a single best practice standard that everybody had to adhere to. We instead focused on a methodology to allow homes to identify ways to improve these quality issues and tackle them in a way that was appropriate for the home. And our collaboration was always characterized by a non-judgmental collegial approach. Everybody had bad findings on something, and so we were quick to reassure rather than judge and work together to try to improve performance where we could. So if I was to think about what lies ahead for us in long-term care of the issues we're going to need to deal with after the pandemic, there's some big problems we've got lying ahead of us. First are all the secondary consequences that came from the pandemic that are not COVID itself. So they're the lingering mental health consequences for residents and for staff in long-term care settings where there were disastrous outcomes, and for long-term depressive symptoms for residents who were affected adversely by isolation. We need to think about how do we remedy the somewhat inadequate management of chronic diseases that happened during the pandemic in long-term care. There are things we didn't do, both in the sector and outside the sector, that are going to come back to us now that we're going to have to deal with. There's the mystery of what are the long-term effects of COVID itself for residents who have been exposed and were ill with COVID. What are the vascular and neurological and other effects that we're just starting to learn about? And then all the bad things that happened during the pandemic, like the example I just gave you of antipsychotic use. We have to reverse those problematic practices to get ourselves back on track of a trend for quality improvement. We're going to have a huge issue to deal with staffing. Staffing is already a challenge in long-term care. It's been a big issue before. I expect we're going to find more challenges once the pandemic is over. People are worn out and have had great difficulty with this for sure. We also have work to do in terms of public trust, both in terms of legitimate negative things that happen in the sector and of some misperceptions that are incorrectly propagated. We have a job ahead of us to ensure the public is comfortable and supportive and trusting of the good efforts that everybody is making in the long-term care setting. We also have to deal with the reality that this sector is not going to get any simpler to deal with over time. There's been a trend since I started my career in the 1980s for much more medical complexity in this sector, and that will continue over time, and we have to be ready for that, in addition to all these other challenges that we face. And we have to keep our focus on the home care system as well. It's been more neglected, in my view, than the long-term care system, and certainly the acute care system has been. And we cannot assume that home care will magically come along and bail us all out of some of these challenges. The home care system is under considerable distress and needs our help as much as the long-term care facility-based system does. We can get there, and I'll give you the quote by Helen Keller to end this off, that alone we can do so little, but together we can do so much. So I think if we put our minds together and work together on this, we can certainly make a difference in the sector to help it get back on its feet and thrive in the post-pandemic world. Thanks for your time and attention. I'm happy to take your comments and questions.
Thanks, Sean. That was quite a lot there to think about. And I'm just going to encourage all our attendees to post questions. Got a couple coming in now. I just wanted to start off, John. I'm just curious in terms of, I'm sure most of the participants on this call know Inter-I, what they do and the organization. But for those that don't, I was maybe thinking you could give us a brief tutorial on Inter-I and the tools, etc.
Sure, I'll give you the elevator speech version of it. So Inter-I is a comprehensive assessment and care planning system where you do assessments on an admission to long-term care and on a quarterly basis to track outcomes, to put in place care plans at the individual level. We can use those data for quality improvement, for resource allocation, all those major applications I talked about, you can use those data. Inter-I itself is a not-for-profit research network of researchers, clinicians, and policy experts that work in long-term care and other settings. So it's an assessment system that is supported nationally in a pan-Canadian reporting system by CIHI, and currently there are 12 provinces and territories that either have implemented Inter-I systems or are reporting that they will be implementing those systems.
Okay, excellent. Great. Thanks for that. We got a couple of questions coming in, so I will read off the first one verbatim. Benchmarking quality outcome scores is hugely beneficial for quality improvement in long-term care. A huge barrier is a lack of knowledge and skills related to the quality improvement process. Do you think there would be value in benchmarking quality improvement processes in the future?
Yeah, I mean, benchmarking is a key part of this. It's what helped us to understand how bad our restraint use patterns were in the mid-1990s to be able to compare with other jurisdictions. But it's also one of the most technically complex areas of health services research. I used to think that funding-based research using case mix classification systems was tricky. Quality measurement and benchmarking is actually much trickier because you have to deal with things like risk adjustment and understanding incidence rates and prevalence rates and so on. I think the reality is for anybody who is a decision maker in long-term care, you do have to upgrade your skill set to be conversant with these types of sophisticated data because the sector is complicated, but we have robust, sophisticated systems to help us manage that. So it's going to be a critical skill set for anybody working in the sector.
Great, thank you. Question from Debbie Delancey, one of our board members. Thanks for a fantastic presentation. Can you comment on how your findings might inform the current initiative to develop national standards for long-term care?
Yeah, I mean, we in fact have a de facto national standard in the form of these assessment instruments. I plan to submit my own commentary to HSO on the national standards. They're currently a bit vague, and to my thinking, I think we could have been a bit more explicit on certain things. When it comes to the Inter-I systems themselves, which is in fact our national standard for most provinces except for Quebec, one of the things that I was hoping we would see in that set of suggestions is the upgrade to the newest standard of the instrument. It might feel a little bit like inside baseball, but here's why it's important. The older instrument is now 25 years old. There's new content that's relevant in the newer instrument, like the tracking of influenza vaccination that you get with the newer instrument. But a really important thing is that CIHI has established a near real-time reporting system so that when data go from the new instrument that New Brunswick is using to CIHI, you can get those data very quickly. So we were able to do that study on the effect of the lockdown in wave 1 in New Brunswick within about 2 months of the end of wave 1. We were only able to get data from the older reporting system between 9 to 12 months after the start of the pandemic, because the old system is part of what's called a batch reporting mechanism. It's not near real time, and it doesn't integrate with the rest of the systems. So it's critical that the country move to that newer standard. There's other points. The standard mentions that assessments should be done on at least an annual basis. That's not nearly enough. This population is much more clinically complex than that. a lot of folks will become very ill or die within the first 90 days. So 90 days is really, in my view, the minimum standard for reassessment. There's lots of other good things that are mentioned in the standards that I'm supportive of, but those are a couple that I'd like to see some more specificity on.
Great. I'm just curious, John, in terms of those tools, what are the impediments or barriers for facilities, organizations to switch to new tools?
It's actually cost? It's the cost around training is fairly modest for it. Software companies may charge an upgrade fee for new release of software. There's no cost related to intri beyond whatever software vendors would be charging. It's actually shorter, so it takes staff less time to complete the new instrument. The care planning protocols are more specific, more tightly focused, so there's less false positive triggering in the care planning protocol. So the economic consequences are that you'll save money by going to the newer instrument and you have better quality data.
Great, thank you. Next question. Thank you for a very interesting presentation. Is there an optimal critical mass for the number of long-term care homes to participate in the collaborative? I.e., is there a minimum or maximum? CFHI, now HEC, has a long-term care plus initiative, which is currently connecting 1,500 plus long-term care homes and retirement residences. Maybe this initiative could be leveraged for one or more collaboratives.
Yeah, I mean, there's probably a minimum size. It's harder to do with much less than 9 or 10 homes. So with the lay visionary group, we had 9 homes that were participating. Everybody got to know each other. It was a very close working relationship. And we had data from 1,500 other homes that we could benchmark the data against. So in terms of sample size for each home, we could see what their performance looked like and compare that to the rest of the country. So it was, what's the critical mass of collaborators that can help you come up with ideas about how to improve quality in your own network? And I think 9 or 10 is about right for that. In the SQLI homes, we have 14 organizations that represents about 70 different homes overall. The CFHI initiative was around 47 homes. 1,500 is going to be pretty tough to do the kind of collaborative network that we've got, but you can also establish local collaborative networks with us as well. And so it's getting the right set of partners there, of people that can make administrative decisions, clinical leaders, scientists that can work with you to do analyses of data. We are certainly keen to having other organizations join the SQLI network. New Brunswick hopes to scale up the Lay Visionaires network. So be happy to chat with folks that are interested in those 2 networks about what they're currently doing. But also you can establish your own network. There's not that much magic in our formula. We work together, we look at data, we analyze our results, we talk about how we can do better. And that could be replicated in any part of the country.
Great, thank you. Just in terms of that and the standards of being created for long-term care, is there any federal initiative or even multiple provincial initiatives to sort of adopt the SQLI sort of process approach? It just seems like with all the great data you have, it would be something that would be a federal initiative where they could lead that sort of thing. Just curious.
So the main provincial initiative would be the New Brunswick scaling up of the CFN Lay Visionaire initiative to a provincial initiative. I haven't seen a federal or another province do that. SQLI is doing this with its own resources overall. And I would also say we're not all that unique in data. We have a data sharing mechanism with CIHI so that we can do the analyses in real time to help the homes that are participating in it. But data is not really the barrier, because the homes that participate can provide those data, and CIHI reports lots of stuff in a way that you don't have to be an intri researcher to access those data. So it's more the leadership and the commitment to collaborating and sharing information internally that's part of the effectiveness of those networks.
Right, great, thank you. Next question. The reason why, I think this is Interi MDS that the individual is referring to, in Ontario is not used for clinical decision-making is because it is next to useless with its gaps in data and multiple different look-back periods. Looking at data on residents every 3 months does not help with day-to-day care. Long-term care homes had to develop several strategies to monitor the day-to-day care of residents. So in addition to the burden of inter-IMDs, the homes have to be developing additional systems for monitoring something as simple as falls. Any comments there, John?
Yeah, that's just not correct. So first of all, when it comes to falls, we've published work out of Nova Scotia that shows that all these extra fall risk assessments that get done do not help. In fact, the inter-eye assessment provides better prediction of falls, better specificity and sensitivity to it that what we often have with some of the homegrown fall risk initiatives is substantial over-triggering with that. So I would not accept that argument, and I'm happy to send an article to that effect. But the person asking the question raises an interesting point about what do you monitor on a 90-day basis versus a daily basis. You don't use the inter-eye assessment to track blood pressure, heart rate, respiratory function, or temperature, those daily things that are in the chart. That's not what we're intended to do. We do track changes in cognition, in mood, in pain, and so on. And those things you can see dramatic changes and can act on those. So you can track changes in those major functional issues with that time period. 30 days looks about right for that. But we also allow for significant change assessments where if the person has had a major clinical event that requires an adjustment of the care plan, you redo the assessment so it's more accurate at that time. So if the person's had a stroke at day 45, you would redo the assessment so it's pertinent to the person's functioning today. But for daily symptom monitoring, of course not. That's not what it's intended to do.
Great. Thanks for setting us all straight on that one, John. Next question. Can you elaborate on how integration with other sectors, hospitals, and home care can improve long-term care?
Yeah, it's a great question, and it's really been something that I've cared deeply about for the last 2 decades. When the lights went on for me to say we should really think about the home care instrument, the nursing home instrument, our acute care instrument, or our mental health instrument as being part of an integrated system. So there's a couple points to the answer. First is, there are people that look just like nursing home residents in home care and vice versa. And from a system management point of view, we want to understand those overlapping populations to refine the performance of the health system. The other thing is from the person's level, in terms of continuity of care, what's important is that if we understand needs prior to the nursing home placement, we can ensure continuity of care to address those needs as the person makes the transition into long-term care. So if somebody has a fall risk that's identified in the home care instrument, that should be communicated with the long-term care home so they can manage that issue. If we look at some of the inquiries that we've had around extreme behavioral events in long-term care settings, those behavioral events would have been readily identified as risks had the home care instruments for those individuals been shared. It's also important because it helps you understand a trajectory of change in the person. So if the person was cognitively intact in home care and not depressed prior to admission to long-term care, and now is confused and is showing signs of depression, maybe something substantial has changed, either not coping with the transition to the new setting, or there's a new clinical event that's happened. We've seen this with the Toronto Grace folks. Some of the individuals that were transitioned from inpatient psychiatry settings in the hospital setting actually had more mental health difficulties in the Toronto Grace setting than in the prior setting in a psychiatric setting. The question is, did the psychiatric setting not do a good job, or did the person not deal as well with a transition going from one setting to another? So you can use it for person level applications and population level applications.
Great, thanks. We're getting close to the top of the hour, but I'll ask you one more question. You say that Quebec does not use inter-eye. What system, if any, does Quebec use, and is it effective? Regardless how effective it is, how do we improve collaboration with Quebec?
Yeah, I mean, it's for as long as my career has been active in long-term care, I've been trying to answer that question. Quebec uses a system called the SMAF at its root, and there's a longer name for the broad package that they're using. The research that went into those instruments is good quality research. I can give you my points of debate about what's missing in that. But I think the reality is that we would not be able to do effective comparisons between the two systems because there's not sufficient compatibility without radically simplifying the concepts that we're measuring in. So if I was, for example, going to show you a quality indicator in a Quebec home using SMAF and an Ontario home or a BC home using the inter-eye assessment, and one of those homes looked worse than the Quebec home or vice versa, the immediate response would be, well, we measured it differently, so it's not a fair comparison. You need standardized, consistent comparisons to be able to evaluate and improve quality. Otherwise, you just don't know if it's just a measurement issue.
Great, thank you. So it looks like we're at the top of the hour, so I think we'll maybe end it there. I want to thank you, John, for a great talk and answering a boatload of questions. I want to remind everyone that's on the call that we do have a webinar next week, March the 10th, so please register. And please let us know if there's any new webinar topics you'd love to for us to develop, and give us feedback in terms of how to improve our webinar. And lastly, of course, I want to thank everyone on the call today. It was actually a very good turnout, and we'll see you next week. Thanks again, John.
Thanks, everybody. Bye. Thanks, Barry.
Bye.